Okay, I can give you the case, doctor.
Yes, doctor. Yes.
Okay, now first I will give you the hint that we have done main airways, bronchus and bronchi and alveoli, bronchiole and alveoli. We have done obstructive airway. We have done. Now we are moving next to the alveoli. So first in the first session we have done all the causes of dyspnea from the heart. This time we will do all the cases from dyspnea from the respiratory system. We have covered bronchus, bronchiole, and alveoli. So next your case is that 165-year-old lady, 65-year-old lady.
What will you do? What do you do?
Yes.
Came to you with dyspnea for 6 months.
Okay.
Okay, dyspnea for 6 months.
Okay. Yeah.
It's your case. Okay.
Station 2, right?
Yeah, it's 2.
Okay. Can I just take 1 minute to prepare?
Okay, you can take. Just 1 minute. Yes, Dr. Sohail added one very good thing that there will be hyperresonance in COPD. Okay, that's a very good thing. Hyperresonance and decreased breath sounds. While in asthma, there will be not resonance. So we can differentiate from 2 things: hyperresonance and decreased breath sounds.
Dr. Muzam,
so
in severe asthma also,
yes,
patient will have a silent chest, right?
Yes, but that will be a silent, and that asthma, will be very severe. Then you can use the other thing that they told, that there will be a resonance. Resonance you can check. Hyperresonance in COPD, but normal resonance in asthma.
Okay.
But they will not put the silent chest in the exam. Very highly unlikely. Silent chest we will not face.
Asthma. They will put asthma in respi case. With such a severe asthma, they will not put, right?
No, severe asthma they will never put. And if a hint for you, that if you are examining the chest and you are finding nothing, you just thinking then why they put this patient, there is nothing, just focus on the intensity of breath sounds. Okay, because in some COPD patients there is just the only finding is decreased intensity of the breath sound. Okay.
Right.
Yeah, if you are thinking that why there is, I am not finding any crackle, any wheeze, just think once, think that maybe it's COPD, because then focus on the intensity of breath sounds. There will be muffled breath.
Okay.
Okay. Okay, Dr. Sarah, you can start.
Okay. Hello. Am I speaking to Miss Jane, 65-year-old lady?
Yes, yes, yes.
Hi. My name is Dr. Ali. I'm one of the doctors in the clinic today. So I understand that you have been complaining of difficulty with breathing for the last 6 months.
Yes.
Could you tell me more about this?
Yes, actually, doctor, I am having this difficulty of breathing for last 6 months. First, I can walk without getting short of breath on flat surfaces. But now, even on flat surface, I have to take some rest because I am getting short of breath.
Okay, I'm sorry for that. So before 6 months, you were completely fine, and then all your symptoms started at that time.
Yes.
Okay, and as you mentioned, it is getting worse now. It is worsening.
Yes, it's getting worse now. Yeah.
Okay, so how far can you walk now without getting short of breath?
How far? Yes, doctor, I can walk just 150 meters, 100 meters. I can walk without getting short of breath.
Okay, and is there anything that makes this breathing difficulty worse?
No, I couldn't appreciate anything that is making it worse.
Okay, and what makes it better? What makes it improve?
No, I couldn't find anything that makes it better.
Okay. Along with this shortness of breath, do you have any cough?
Yes, doctor, I have cough.
Did it start at the same time with the shortness of breath?
Yeah, I started at the same time. Yes.
Okay. And do you cough up any phlegm?
No, doctor, no phlegm.
Okay, so it's a dry cough. Okay. And is there any chest pain?
No chest pain, doctor.
Any awareness of your heartbeat?
No.
Okay. Any? Do you feel this difficulty with breathing when you lie flat?
No, doctor, no.
And do you ever wake up at night gasping for air?
No, doctor. Very good, doctor. Very good approach. Yes. No, doctor.
Okay. Did you notice any swelling of your legs or of your feet?
No, doctor. No, doctor.
Okay. Any wheeze or any noisy chest?
No wheeze, doctor. No, I cannot find any.
Okay.
No whistling sound. I cannot appreciate.
Okay. And do you have any joint pain?
No, doctor. No joint pain.
Have you noticed any skin rash?
Skin rash. No skin rash, doctor.
Or any changes in your skin? Any tightness of your skin?
No, doctor.
Okay. Have you ever been diagnosed with any medical illness before?
No, I don't have any medical illness. I am living quite healthy life.
Okay, good. And you didn't seek any advice for this breathing difficulty before? Have you seen your GP?
No, I didn't see because it's one not disturbing me a lot. Recently started to disturb, so I went to my GP and he sent me here.
Okay.
He gave me some inhalers, but there was no benefit for that.
Okay, they weren't helpful. Okay. Is there any fever?
No fever, doctor.
Okay. Any excessive sweating?
No sweating.
Okay. Any, how about your weight? Any loss of weight?
Loss of weight, no doctor. I couldn't appreciate any loss of weight.
And no change in your appetite?
No change in appetite. Yes.
Okay. Any lumps or bumps anywhere in your body?
No lumps and bumps.
Okay. And you said that your GP prescribed you some inhalers and they weren't helpful. Is there any other medication are you taking?
No medication, doctor. I'm taking.
Okay. Any allergy to anything at all?
No.
Okay. And any history of, as you mentioned to me that you are previously healthy, so no previous hospital admission or any surgeries before?
No previous, no doctor, no my admissions, no surgery, no surgery
No,
before.
no any other medical procedure.
No medical procedure.
Okay. Is there any other member in your family having the same condition, suffering from the same problem?
No.
Okay. Um, just want to ask you a few questions about your health in general. You said that your appetite is good. Do you have any symptoms of heartburn or feeling acid sensation in your mouth?
No doctor.
Okay. Any feeling sick or throwing up, vomiting?
No.
How about your bowels? Any change?
No change in the bowel.
Okay. What about your water work? Hello?
Hello. Yes, doctor. Yes. No change in the bowels.
Yeah. No change in water work. Okay. Right. Any headache or any migraines?
No headache, no migraine.
Okay. Any weakness or numbness in any part of your body?
No.
Okay. Right. Just want to ask you some other question about your life in general. Who do you live with?
I am living with my. I have one son and his family, and we are living together.
Okay. And you live in a house?
Yeah, in a house.
Okay. Any change in the furniture or any damp in the house?
No furniture change. And what else?
Damp? Any damp?
Dumb? No dumb.
Okay. Any pets at all?
Yeah, I have. I on the birthday of my grandson, I give him the gift of one pigeon.
Sorry, what's that?
Yes, I have. We have one pigeon at home.
Pigeon. Okay.
One pair
And
of pigeons.
when did you get these pigeons at home? Was that before 6 months, coinciding with your symptoms?
Yeah, on the birthday of my grandson, I took that. It was almost 6 months ago.
Okay. Right. Any other animals at all?
Sorry?
Any other animals?
No.
Okay. And do you smoke?
No, I don't smoke.
What about your alcohol intake? Do you take alcohol?
No.
Okay. Miss Jane, can you tell me what's your job?
Yes, doctor, I'm not doing any job.
Okay, and how is these symptoms? How are they affecting your life?
Yes, doctor, I have limited myself to the home, and first I was very active lady. I used to do my daily activities myself. Now I feel that I will have shortness of breath, and so I'm not going outside. I'm not doing my daily activities, not doing grocery. So it's really a problem for me.
Okay, I'm so sorry for that. This must be very difficult for you. Okay, is your son or your family helping you with your activities?
Yeah, they are helpful,
Okay, that's
but
good.
don't want to be dependent on them. That's why I'm very concerned about this.
I appreciate your concern. I understand where you're coming from. Just to reassure you that we will do our best to find out the cause of your problem and try to treat it and help you with that. Okay. Just to ask you a few more questions. Have you traveled anywhere recently? Hello? Can you hear
Yes,
me?
now I can. Yes, it's okay. Now I can.
Okay, I was telling you that we will try our best to help you with your symptoms and to solve your problem. Is that okay? Hello?
Voice is not clear. Hello.
Can you hear me now? Hello?
No, it's okay. Yeah, it's okay now.
Okay, Miss Jane, I was telling you that I appreciate your concern. We will try our best to find out the cause of what's causing your symptoms and to help you to offer you treatment.
Okay, okay, doctor. Thank you.
Okay. Just want to ask you a few more questions. Have you traveled anywhere recently?
No, doctor.
Okay. Is there anyone in the family who is sick or suffering from cough?
No.
Okay. Okay, right. Okay, Miss Jane, can you tell me what is your concern?
Yes, doctor. Why I am getting short of blood?
Okay, Miss Jane, from after our discussion, I need to examine you and listen to your chest, but most likely from what you told me, I think you have some sort of an allergic reaction to the pigeons at home. They can sometimes affect the lungs and cause some sort of an inflammatory or some soreness in your airways. And this is the likely cause that's giving your symptoms of difficulty with breathing and the cough you are having. Are you following me?
Yes, doctor. It means,
Okay.
doctor, if I will get rid of this pigeon, then I will be okay.
Yes, we need to eliminate the source of this allergic reaction. This is the first step, but then sometimes these reactions can last for a long time, but we can give some treatment to help relieve your symptoms, and it can take some time until it fully recovers. Do you understand what I'm saying?
Okay. Yes, doctor, I understand. Yes.
Okay, so what we need to do now, we need to do some investigation, some tests, blood tests, and also a scan, imaging of your chest, and to confirm this diagnosis and to rule out any other possibilities. And then we will arrange another meeting to discuss the results. Okay? Do you
Okay,
have
doctor.
any more questions?
No. Thank you.
Okay, thank you.
Okay, doctor. Thank you. Yes, doctor, very well done. Yeah, you with a good approach, and you fulfill all the this one requirements. Your clinical communication, your patient concerns you asked, judgment was right, and your plan was also right. But you can tell the patient that it's first of all we have to remove that will be definitely will be beneficial for you. But or not, we can answer in a better way after doing the other investigations for scans of your chest, because we need to see how much lungs is involved, and I think in 6 months maybe there is no some cases, if there is extensive involvement, there are chances the recovery will not be full. So be political and tell the patient that this is the best step that we will do. We will remove that vision, but how it will reverse the condition, this will be decided by in follow-up and after your investigations like this.
Okay.
It's okay. Case was good. Guess what investigation you will do for this patient?
Okay, I'd like to do some basic investigations, including full blood count, inflammatory markers, and basic liver and renal function. And then I'd like to do precipitine tests for the region allergens. I'd like to obtain a pulmonary function test, formal spirometry, this is the total lung capacity and the full horse vital capacity and FEV1. Also, I'd like to get a basic chest X-ray, looking for any infiltrates, and a high-resolution CT scan, looking for any signs or any features of parenchymal disease.
Hypersensitivity pneumonitis, yeah? You are telling?
Yeah, my diagnosis is extrinsic allergic alveolitis.
Okay, they are.
Hypersensitivity pneumonitis.
Yeah, nowadays I think they are saying hypersensitivity pneumonitis. Extrinsic allergic alveolitis is also the name of same thing. You are right. Actually, this is the hypersensitivity pneumonitis that is due to the pigeons. What is the difference between hypersensitivity pneumonitis and occupational lung disease? The same things happen in the occupational lung disease, and there is ingestion of the particles, and then there is chronic fibrotic changes. Why we are not? What is the difference between them?
I'm not exactly sure. Maybe it's maybe there are some eosinophilic infiltrates in hypersensitivity pneumonitis. I'm not sure, doctor.
Actually, as much as I understand, the difference is that in hypersensitivity pneumonitis there are organic particles. Okay, like protein, like allergens are organic. Okay, for example, if there is a farmer, there are hay or other things. You know about hay? What is this hay? Farmer's lung?
Yeah, yes.
Hay.
Hay
In Arabic, this is kash. Kash. You know kash?
Yes. Yeah.
High fever, high fever.
Yeah, hay fever also maybe, but this I am telling the Arabic word for hay. This is kash. Okay, but in Pakistan we can say it similar to in English it's fodder, but in Pakistan we can say it's similar to, I think we can say the and so it's the difference is that in one case there is organic particle ingestion. Hypersensitive pneumonitis patient is having a classification of organic particles, and occupational lung disease may be the metallic inorganic particles. In all these situations, patient ingest these things and they enter the alveoli, then there is some inflammatory reaction, then there are fibroblasts are coming, and then they causes the interstitial. We will see the restrictive pattern in this case. Okay, restrictive pattern in hypersensitivity pneumonitis. Okay, so we have moved to the first interstitial lung disease. We started from the alveoli. This is extrinsic allergic alveolitis. Now we will move one step behind that, because today we need to complete the whole lung. We have done bronchus, bronchiole, then we did the bronchiole plus alveoli, COPD. Okay, first we did the only bronchus, a main bronchi, that was asthma. Then bronchus plus alveoli, that was COPD and bronchogenic carcinoma. Now we are moving to the after alveoli. First thing was extrinsic allergic alveolitis. Next thing is also, next case is station 5, and in which we will do this. These things will become more clear about ILD. In that, after that case, we can discuss in a better way about this ILD. All these are the real exam cases. Okay, but just I have arranged these cases in such a way that you got better idea. So in your mind, you got about whole respiratory system. Stepwise, you can have the approach that when is the obstructive, when is the restrictive, and how the patient will present to us, how the COPD, how bronchiectasis, how the asthma. Okay, so we will do the next case, that is station 5. Dr. Sara, your case was good, very good case.
Thank you very much.
Inshallah, it will be very good marks, full marks, inshallah.
Thank you, Dr.
Okay, and next case, according to the list, is Dr. Nahid. She is here. It's a station 5 case. If she is here, okay. Otherwise, yes, doctor, your name is here. If you are here, you can unmute your speaker. Then otherwise, we will move to the next. Next is Dr. Rashidul Islam is here. Okay. Okay, then hello, you can hear my voice. After Rashidul Islam, Dr. Shraddha.
Yes, Dr. Nazir.
Yes, yes.
Yes, I'm here. I'm Nahid.
Okay, okay. It's station 5. You can take the station 5. Your case is that a very common case, doctor. It has appeared 3-4 times in the exam. Okay, not only one time. It is also a case of rider Mir, and it's also a real exam case, not only 1 or 2 times, multiple times this case has appeared. So this case is that one 45-year-old lady with dyspnea for 2 months. Hello, you can hear me?
Yes, Dr. Nazir, we can hear you.
Yes, your case is 45-year-old lady with dyspnea. You can hear me? Yes, doctor, you can start.
Yes, Doctor.
Yes, yes, you can start.
Okay. Hello, I'm Dr. Hussein, one of the doctor in the clinic.
Hello, doctor. Please unmute your speaker. Hello.
Yes, Dr. Nazir. Yes, I'm here.
Yes, yes, continue.
Yes. Hello, I'm Dr. Hussein, one of the doctor in the clinic.
Yes, doctor.
May I confirm that I'm talking to Miss Sarah?
Yes, doctor.
Nice to meet you. We are here today to discuss some issue regarding your health conditions. That is okay with you?
Yeah, it's okay with me.
I understand that you have been troubled by this shortness of breath. Can you tell me more about it?
Yes, doctor, I am having this shortness of breath for the last 2 months, and it's mainly on exertion, and when I take rest, it get better.
Okay. For how long do you have this?
For 2 months,
Okay. And how does it start?
gradually it started.
Okay. Do you have any shortness of breath when lying flat?
No, doctor, no.
Do you have you ever awake at night feeling breathless?
No,
Any lower leg swelling?
no, doctor,
Any chest pain?
no,
Any cough?
no, doctor, no cough.
Any coughing up of blood?
Sorry, doctor, I have cough. I have cough. Sorry, I have cough.
Okay. Uh, cough.
Cough is a dry cough.
Does it contain phlegm?
No, dry
Dry
cough.
cough. Okay. Have you ever coughed up blood?
No,
Okay. Do you have any runny nose?
no, doctor, no runny nose.
Okay. Do you have any medical condition I should be aware of?
Yes, doctor, I am a diagnosed case of rheumatoid arthritis for the last 12 years.
Okay. And do you take any medication
Yes, I am taking the
for that?
medicines. I am taking ibuprofen for the pain, and I am taking methotrexate.
For how long do you take methotrexate?
This is for 6 years.
Okay. May I examine you? Before I examine you, do you smoke?
No, doctor, I don't smoke.
Do you drink alcohol?
No, I don't drink alcohol.
What is your job?
I am a worker here in the hospital.
What is your type of job, please?
I am here in the hospital. I am on the appointment section. My job is in the appointment section in the hospital.
Okay. May I examine you?
Yes, doctor.
Okay. I want to examine the chest. Start with the chest for basal crackles. Any basal crackles? Basal?
Very few basal crackles. Very few. Okay.
Okay. Okay. You want to
Difficult to
examine
hear.
for
Yeah, there are crackles, but
okay. You want to know if it is change with cough?
no, they are not changing with cough.
Okay. I want to examine the eye for
Yes.
pallor and jaundice. I want to examine the mouth
mildly paler.
for
Mildly paler.
okay. You want to examine the hand. I want to see if there is deformity, rheumatoid deformity.
Yeah, there are deformities.
And I want to see if okay. You want to see to know if there is active inflammation, any tenderness, any high temperature.
No tenderness. Yeah.
I want to assess any wasting of a small muscle of the hand and to assess for the power and sensation.
They are normal.
You want to assess the function of the hand.
Okay, function is okay.
You want to assess for pulse.
2 minutes remaining, doctor. Yeah.
You want to see the rheumatoid nodule.
No rheumatoid nodule.
Okay. What may I know? What is your concern, please?
Why, doctor, I am having this shortness of breath?
Okay, from the information examination I did, you are most likely having scarring in your lung. There are many possibilities for that. You may have this rheumatoid disease affected your chest, or it may be due to side effect of the medication you take for this rheumatoid, which is named methotrexate. For that, I want to do some blood test and imaging to confirm this. After that, we can you in a multidisciplinary meeting involving the lung doctor and the occupation therapist. I
Okay,
may need to do some blood test and imaging. Do you have any other concern?
no, doctor. Is it reversible, doctor? It will get better.
I don't think it is reversible, but after imaging we can decide. We can help to reserve the rest of the lung.
Okay, doctor.
And in case of
Asked for me paler. I said yes, she is pale. Okay, but she at that time she should think why she is pale. In such cases, there are always more than one causes for the dyspnea. If you ask me from this case, first thing is that stick to the scheme, doctor. Why you didn't? It's good that you ask occupation. Why you didn't ask the pets at home? Okay, maybe a rheumatoid arthritis bring the pets at home and she started to have dyspnea. Is it a guaranteed that whenever she will have dyspnea in the life, she will be due to interstitial lung disease or she may be due to rheumatoid arthritis? If a normal person can develop hypersensitivity pneumonitis, she can develop the hypersensitivity pneumonitis from the pets. So if she is pale due to myelosuppression because of methotrexate or she is taking brufen, you should ask about epigastric pain and melena. If she is anemic due to epigastric or pain or melena, this anemia may worsen the dyspnea. Because if crepes are very few crepes, okay, but still patient is dyspneic, so they will expect from us that we can understand that in such case, in this patient, there may be multiple causes of the dyspnea. This drug and interstitial lung disease is one of the factor, and also we need to rule out the anemia. Anemia may be due to methotrexate, anemia may be due to anemia of chronic disease, and anemia may be due to melena because she is using brufen. So don't tell only one cause for this patient and ask all questions for the dyspnea. Ask about the pets. It's good you ask about the occupation. Ask about the other things as well. So maybe they can give you this scenario. They in nowadays they will not give you such a so simple scenario that patient with rheumatoid arthritis started to have dyspnea. It's due to interstitial lung disease or due to rheumatoid arthritis or due to methotrexate. So such patient they are expecting from us to think in multiple directions. They are expecting this. When you were taking history, I realized that you are thinking in multiple directions. It was very good history. that you ask about: heart, left heart, right heart, coughs, dry, phlegm, fever. That was a good history. But when you just listen rheumatoid, you leave all these things and you just focus yourself to the interstitial lung disease, or don't make your mind about first they used to assess us that whether we know the complication or not. Now they are expecting from us that we if any patient we see with dyspnea, and if we came to know that it's rheumatoid, they're expecting from us that we should not direct jump to the interstitial lung disease, we should not direct jump to the methotrexate. Okay, they are expecting from us to think in multiple ways, because that patient may have the other causes. So it's good, your history was good, but when you were doing examination, people ask about the, you didn't put the anemia. Anemia is a cause of dyspnea. So
And
in
doctor,
this case, multiple
there was no ask
myelosuppression,
and
anemia of chronic disease.
sorry, doctor, there
Yes,
was no ask
jaundice,
about jaundice. There was no ask about jaundice and abdominal examination. Maybe
anemia
methotrexate
of chronic
toxicity or no
disease.
need for
Yes,
abdominal
jaundice is,
examination for hepatotoxicity of methotrexate.
no, doctor, I don't think so. For this one, abdominal examination is required in this case. And she asked about the jaundice. She told me that is pallor or jaundice. I told there is pallor. Okay. So she asked about the jaundice. It was a, she did good, but just need a little bit to be more think and should think about in multiple directions. The same thing we were discussing on that day, that nowadays everyone who is hearing that this patient is delivered and is having fatigue, all of us we are thinking at Shihan. We should not stick to one diagnosis. We should think different possibilities as well. Okay, you people agree with me? Okay.
Yes, doctor.
Yes, always think, because if they are giving such a simple scenario, they are expecting you little bit different. Like for example, thyroid. In nowadays, if you are finding thyroid, must think that they are testing you for treatment, complication of treatment, you of thyroxine. They will not say just you will enter and you will say, no one has ever told me like that. He entered in the room and his case was Graves' disease. All the candidates who are facing grave disease, whether they are facing this due to diplopia, or they are facing this due to hypothyroidism after surgery, or they are facing this after surgery hyperthyroidism due to taking more thyroxine, okay, or they are facing this grave disease weight gain after thyroidectomy and not taking thyroxine. So think in actually we need to broad our thinking. One candidate, he asked me to do a case with him on the phone. When I did, and I give him the case that this patient is young patient and he's a worker in the hospital and he's a cleaner and he's having backache. Okay, and when he did the scenario, it was ankylosing spondylitis. Then he said, how you give me the scenario of ankylosing spondylitis? It cannot be ankylosing spondylitis. Patient was having no loss of lumbar, no kyphosis, no loss of lumbar lordosis, and he was a young cleaner, nothing in this. So I was thinking that actually we are doing the clinical courses. In clinical courses, they are showing. I was thinking, we need to broaden our thinking. I will speak ankylosing if I will see a big hump, if I will see apical fibrosis, or like actually the in real life in our countries the patients are presenting like this, that there is a big hump and no one has diagnosed, and now you saw the patient and you say, oh yeah, this was ankylosing spondylitis, it was missed, no one diagnosed for the last 10 years, now it's complication. They are bringing the patient in the exam, young man, college student with backache, not even a single deformity he has, not even a single complication. But if he has backache more in the morning with stiffness, morning stiffness, even you cannot find anything. Even if you are doing exam in the third part, in the if they are expecting from us to be logical. If you are doing exam at 3 o'clock in the evening, even he will show you the proper movements. Okay, he will show you the range of movements normal. If he will show the decreased range, he will show a little bit decreased. He will show we are expecting after clear that when he will bend, he will say I am unable to bend. He is unable to move the neck. Okay, because ankylosing spondylitis can come a very handsome smart boy, college student, having no deformity at all, having backache. Okay, it can happen. He may develop later on the complications. Okay, so always think in multiple directions. Don't just make discuss with other people. Discuss lot of discussion will make your mind sharpen on that day. Okay, on that day your mind will be sharp if you have discussed these cases with a lot of people, discuss again and again, then you can perform well on that day. Otherwise, if you will only you will keep on studying, then you will have different views in your mind. The same person, the candidate, he became uh, very surprised that how a young man can come with ankylosing spondylitis, because recently he did a course from Sudan and he has seen the patient there with the ankylosing spondylitis, and he was saying that patients are ankylosing spondylitis are not like this. Okay, you understand my idea? So
Yes, sir.
okay, next case is also a good case. Okay, actually we are now in a half an hour, inshallah we will finish. Actually 2 cases are left. I want to finish it because maybe there the next session may be a little bit late, so I will finish. The next case is a very good case. According to the list, name one doctor has exam on 11 March, Dr. Khan. If she is here, it's okay. Otherwise, next is Dr. Farah. She is here. Okay, if she is not here, then we are left. Again, we will start the new list according if it means we have completed in this one that we have made in this session. From the next list, we will start from Dr. Sabah. She is here. If we have Sabah, she is here. Okay. If she is not here, next, who has the nearest exam in the near future can take this case. It's a good case.
Yes, sir.
Mine is 15 March.
In the February, anyone has exam in the February?
Yeah, me, Dr. Hafiz.
Yeah, Sohaib. Yes. Sohaib, you will take this case. It's a good case, but I think maybe you have an idea about this case. Okay.
Okay, I can take the next one if you want me to.
Okay, you take the next one. Okay.
Okay.
Anyone
Shall I do
else who
it?
has exam in February? Doctor Haji? Who wants to do?
Yes, me. I
Okay,
have on
Dr.
15 March.
Okay, you can take this. No problem. Sajid, you can take it. Okay.
Thank you, sir.
This young lady, 22-year-old lady, with the difficulty of breathing, dyspnea.
Okay, name?
Name of this lady is Jennifer. You can put the name Jennifer.
Okay. Okay, we can start.
Okay, doctor, station 5. Okay.
Hello, good evening. My name is Dr.
Dr. Salik.
Iqbal.
Dr. Salik, it's a good case. If you will pick this case, inshallah, you should be very confident that you will pass. Okay. It's a good case. Okay, start.
Okay. Hello, good evening. I am Dr. Iqbal, one of the doctor in the clinic today.
Yes, doctor.
Are you Miss Jennifer, 22-year-old?
Yes, doctor.
Nice to meet you.
Nice to meet you, doctor.
So I have a letter from GP mentioning about you that you have some difficulty in breathing. Please tell me more about it.
Yes, doctor. Actually, I am having a difficulty of breathing since morning. I feel that I feel very suffocation and I feel a drowning like sensations. And doctor, actually yesterday in the morning, I have some cough and a little bit this one sore throat and cough, and I was feeling very fatigued. And but now today morning, it's very difficult for me to breathe.
Okay. So did it started suddenly or gradually?
Today morning it suddenly worsened.
Okay. So were you all right before yesterday?
Yes, before yesterday I was all right. Yes.
Okay. So what do you mean by difficulty in breathing and suffocation?
Yeah, I am feeling difficult to breathe, and I feel that my I feel like a suffocation. And doctor, I am seeing doubles at time. For me, I am seeing when I seeing you, it look like double.
Okay. So is it the doubling worse as the day passes, or is it all the day?
Yeah, it's since morning I have, but yesterday it was in the evening.
Okay. So do you get fatigue usually?
Yes, sometimes I feel that I get fatigued easily.
For how long are you having this fatiguability?
Yeah, easily. For the last 2-3 years, I feel fatigue most of the times.
Okay. Okay. Is it in the evening time usually?
Yeah, usually in the evening time.
Okay. So do you have any difficulty in swallowing?
Sorry, again.
Difficulty in your speech?
Yeah, I am feeling difficult to speak.
Any difficulty in swallowing?
No, I couldn't appreciate any difficulty in swallowing. Since morning, I didn't take
Okay.
anything.
Okay. Do you have okay? So about your double vision, is it in specific direction or is it in all direction you are having?
Double vision is in all directions.
Okay. Have you used recently any medication?
Yes, doctor. I just take symptomatic paracetamol.
Okay. Any medical condition I should be aware of you?
No, doctor.
Okay. And can you tell me your medication list?
Only I took paracetamol.
Okay. Any family history of any illnesses?
No.
What do you do for your living?
I am university student, doctor.
Is it affecting your quality of life?
Yes, doctor. Due to fatigue, my my university performance is affecting badly, and now the problem since yesterday, I feel really very fatigued, and I
I'm
miss my
sorry to
university today.
I'm sorry to hear about this. So, do you have any joint pain?
No joint pain, doctor.
Any skin rash?
No skin rash.
Any altered bowel habit?
No altered bowel habits.
Okay, I would like to examine you if this is all right with you.
Yes, doctor.
Okay, so I would like to check for the drooping of eyelids in inspection, if there is any drooping.
Yeah, there is drooping of eyelids. Yes.
I would like to perform fatigability test by checking the proximal muscle weakness and then performing the fatigability.
Yeah, it's positive. Fatigability test is positive.
Okay, I would like to check for extraocular movement. I checking for diplopia. If it is specific direction or
multiple direction.
Okay, I would like to look to the neck for any neck swelling.
Neck swelling? No neck swelling.
Okay, so I would like to auscultate the chest for any decreased breath sounds and perform chest expansion to reducing any chest expansion.
Is reduced. Chest expansion is reduced.
I would like to check all the vitals for saturation, especially in bedside force expiratory volume, force.
2 minutes remaining, doctor.
So, what have you concerns for me?
Doctor, yes.
What are your concerns for me?
Why I am having this difficulty of breathing and fatigue?
Miss Jennifer, most likely, what is in my mind is that you are likely suffering from a condition which is called as myasthenia gravis. It's a condition in which the body immune system mistakenly attacks the muscles in your body, and that is giving rise to fatigability. The muscles get fatigued easily. Are you with me?
Yes, doctor. Yes.
Sometimes it can affect the muscles of your swallowing and breathing as well, which is an urgent situation, and you need to be admitted for this.
Okay, doctor. Okay.
We need to start you on urgent treatment with the we need to monitor your condition in intensive care unit. Is this all right?
Yes, doctor. Yes.
Okay. Do you have any other concerns for me?
No, doctor.
Okay.
Okay. Thank you, doctor.
Thank you.
Yes, excellent, Dr. Sajid. Excellent. Okay, you very good. It was myasthenic crisis, and precipitated by viral illness. Myasthenia crisis. Yeah. Here, the purpose of giving this scenario is that we are, for example, one candidate faced the abdominal pain. Okay, and this was a young lady with abdominal pain. He asked from the patient, pain and vomiting. The candidate asked from the patient, you are taking any steroids? Okay, in England, this case, and the patient told, no, I have never taken any steroids. And when the case finished, and he was moving here and there for causes of vomiting and for causes of abdominal pain. When the case finished, the examiner told him that, why don't you think about addition? Then he told the examiner that that is the crisis is a complication of the disease. How she can present with the crisis? She should be a known case of addition to present in Addisonian crisis. Otherwise, she should take the steroids. But doctors, many diseases have their presentation in the crisis phase. Okay, like this case, she has fatigue for long time, but she just didn't bother it. But when there was a precipitant, she got the precipitant and she presented with crisis. Okay, same the Addison can present with the crisis. Addison can present with abdominal pain and vomiting. Okay, because patient has fatigue, may have fatigue for long time, but this time there may be any event. Even if this patient has taken some antibiotic, levofloxacin, ciprofloxacin, or azithromycin, she can present with myasthenic crisis. Okay, so the purpose of giving this case is that patient can present to us first time with the crisis. Okay, whenever we are having in our mind the diagnosis, as you did very well, put it in your mind that this may be crisis, because diplopia is a feature of myasthenia, fatigue, and diplopia. She was having this disease, but this viral illness unmasked the disease of this patient. So very good, Dr. Sajidi. Mashallah, you are well prepared. Okay. Actually we did now this is the neuromuscular junction. We are moving step by step. We did the bronchi, bronchioles, then alveoli, obstructive lung disease we did, asthma, COPD, bronchiectasis, and bronchogenic carcinoma. Obstructive disease we did the first two scenarios. Then we moved to the interstitial lung disease. Then we did the interstitial lung disease due to drugs or due to connective tissue disease. First, we did the hypersensitivity pneumonitis due to extrinsic factor like pigeon. Okay. Then we moved to the neuromuscular junction. This was the dyspnea due to neuromuscular junction. And there is another case that Dr. Sohaib will do. This will our final case. This will finish our test, inshallah. So, Sohaib, you are ready for this case?
Yes, I'm ready.
Okay. Your case is 32-year-old male.
Yes.
With dyspnea.
That's it.
Yeah.
That is it.
With this, that is oxygen saturation is 92.
Fine.
Respiratory rate is 22.
Okay.
Pulse is normal.
Okay.
Other vitals normal. Afebrile.
Okay, 2 minutes.
Yes, take your time. Okay, that I was telling that we may face the disease in the very beginning. Another example came in my mind that you may face a patient, a young lady with very neat and clean hands with the joint pain. Okay, in that case, if you think that she has no Z deformity, she has no Butrinian deformity, how she can be rheumatoid? If she is presenting to you in the first time with the joint pain with morning stiffness, even there is not even a single deformity in the hand, neat and clean hands, even there is a medical student sitting there in the exam, you need to put a differential diagnosis for rheumatoid arthritis. Okay, because the disease, it depends upon the timing of presentation. The first time, whenever she will present just stiffness and pain. Okay, at this time there will be no deformity, highly likely there will be no swelling. Okay, so always think about all these issues. So okay, so you can start.
Good morning.
Good morning, doctor.
Mr. Smith?
Yes, I'm
Mr. Smith, I'm Dr. Sohaib, one of the doctors in the ward today. Nice to meet you.
Nice to meet you, doctor.
Mr. Smith, may I confirm you are 32 years old?
Yes, doctor.
All right. Tell me what brought you to the clinic today?
Yes, doctor. Actually, I am having difficulty of breathing. When I walk a little bit, I feel that I'm getting short of breath. and I am having this problem for the last 6 to 7 months.
Well, sorry to hear about it. I will try to help you with this. Is there anything else you want to tell me?
No, doctor. What you want to ask? You can ask. Nice to
Any
meet
other
you,
thing?
doctor.
Okay.
Yes,
Okay.
doctor.
Tell me that how has it started? Was it sudden or gradual?
Slowly it started.
And how has it progressed?
It's progressing over time. Yeah.
All right. Anything that helps you with the shortness of breath?
This shortness of breath. No, doctor. I don't find. I couldn't find anything that is helping.
All right. And you mentioned you get breathless on walking only.
Yeah.
And taking rest will help you or no?
It helps me. Yeah.
All right. All right. Do you have any shortness of breath at night? You need to wake up with shortness of breath?
No, doctor. Actually, for all of the night is disturbed for me. I am having this problem of ankylosing spondylitis for the last 10 years, and I cannot lie straight because of this problem.
All right. So because of pain, you are unable to lay down, or because of this shortness of breath?
Because of this deformity at my back.
All right. All right. So you have any fever?
No, doctor.
Any cough?
No cough.
No cough. Are you allergic to anything?
No, doctor.
Have you ever
Sorry.
coughed up blood?
Sometimes I have cough. Sometimes I have cough, dry cough. Sometimes.
Dry cough.
But not.
Have you ever coughed up
Not.
blood?
Rarely I have this cough. No, never. I never cough.
All right. Any recent change in your home?
No, doctor.
Any recent change in your occupation?
No, doctor.
All right. Any new pets at home?
No, doctor.
All right. And what medication you are taking?
Medicine I am taking, doctor. Pain medication I am taking this brufen, and I am taking methotrexate.
All right. And for how long you taking?
It's 6-7 years I am taking.
So, do you have any pain in the tummy?
No.
Ever passed black color bowel habits?
No.
All right. And for how long you're taking methotrexate?
6 to 7 years.
6 to 7 years. Any recent change in your medication?
No recent change in the medication.
All right. You have any changes in your weight?
No, doctor. No change in the.
All right. Any night sweats?
No.
Any lumps and bumps in the body?
No.
All right. Do you smoke?
No, doctor.
Do you drink alcohol?
No, doctor.
Where do you live? In a flat or in a villa?
In a flat.
So how are you managing your living? Are you able
Yeah,
to
actually, this problem of difficulty of breathing has limitations on my life, but my family is supportive, so they are helping me these issues.
And you don't smoke and drink?
No, I don't smoke.
All right. I would like to do some examination for you.
Okay, doctor.
First of all, I'll starting from the hand. I will look for pallor, pulse. In the eyes, any pallor or jaundice?
No pallor. Pulse is normal. There is a kyphosis, loss of lumbar lordosis, big deformity at the back. Visible deformity.
All right. Visible deformity. I would like to check the expansion of the chest.
Yeah, reduced expansion of the chest.
Both sides.
Yeah, all over the chest, reduced expansion.
I would like to auscultate the chest.
Yeah, no crackles, no murmur, no wheeze.
How about the breath sounds?
Normal intensity of breath sounds.
Normal intensity. And use of accessory muscles?
Doctor, 2 minutes remaining for you. Not using the accessory muscles.
All right. And any problem with the eyes? I want to look for eyes.
No problem in the eyes.
I want to check this wall occipit.
Yeah,
test.
there is wall.
There is obvious.
Yeah, obvious distance. Wall occipit.
All right. So, what are? Tell me, Mr. Smith, what are your primary concerns?
Doctor, my concern is that why I am having I'm already I have a lot of problems because of this disease. Now this new problem has developed for me. Why I am having this shortness of breath?
Well, Mr. Smith, I feel sorry for you, but I must tell you that this your problem of shortness of breath is a part of your previous problem, which is making your chest abnormal shape. And this, because of this, your lungs, they are unable to expand, as your chest muscles, they are not expanding properly, and this is making you short of breath. So this is the part of your previous problem.
Okay, doctor. Is there any treatment for this?
We will involve a team of doctors, and that can include your muscle strengthening exercise, and we can look into this. But I'm sorry that I don't think there is any way to reverse this condition. But we can improve we can preserve your current breathing efforts.
Okay, doctor. Okay. Thank you, doctor. Thank you. Yeah. What is the cause of dyspnea in this patient, doctor? What can be the causes?
This patient has a obvious kyphoscoliosis, which is restricting the expansion of the chest and making him short of breath on exertion. Also, there could be possibilities of
yes.
Although could be possibility of apical fibrosis, but ruled out by normal chest auscultation. And
very good, doctor. Very good. Any other possibility left? You have got full marks, but any other possibility we can think about?
Well, with normal chest auscultation, only possibility left is maybe anemia because of ibuprofen.
Yes. No, and there is no anemia in this patient. As you check the pallor, and there is no melena. So one possibility left, but in this case, not in this case. I am just telling you for the information. This valvular heart disease can cause dyspnea in this patient as well. Okay, but in that case, you will find the fine crackles at the basis. Okay.
Yeah. He might have shortness of breath at night time, orthopnea.
Yeah, he may have orthopnea, PND, if it's due to severe aortic regurgitation or leading to the left ventricular failure. Okay. So valvular heart diseases are a common cause of heart failure. So he may have. This is not in this case. In this case, this was the chest restrictive lung disease due to the chest deformity is the diagnosis. Okay. Restrictive lung disease due to the chest deformity is the diagnosis in this case. But if you need to just to think about if they keep on asking what other can cause, you can say anemia. You are right. If no anemia, then you can say apical fibrosis. If no apical fibrosis, you can also say valvular heart disease. Okay.
Regarding answering to his condition that this can be helped or improved
Which one? Regarding?
Answering his question of what we can do for this condition.
Yes, we can improve. We can involve the team, but there are less chances to improve in this condition. We will tell him there are less chances to improve this condition, but we will involve the physiotherapist and we will involve the multidisciplinary team, including the lung specialist and chest physiotherapist, and they will help you regarding this. But there is no reversibility of this. You know, this is a bony deformity. Now, how we can reverse this bony problem?
No, we can
This is a
say this to the
skeletal
patient that it's difficult to reverse the condition, but we can try to preserve what's left.
Yeah, we can try to preserve, and we will try to make you feel comfortable.
And they have
We will
any
try
role of exercise in this one? Chest exercises, chest rehabilitation.
Yeah. All restrictive lung diseases are pulmonary rehabilitation program. They will be in the pulmonary rehabilitation program, because the pulmonary rehabilitation program also strengthen your muscles of the respiration as well. Okay. So all of chronic dyspnea will be registered in the pulmonary rehabilitation program. And the same, they also need psychological support. Yes, doctor.
Sorry to interrupt. Any role for orthopedic surgery for treating this condition?
I don't think so. There is a role of orthopedic. I don't think so. In my opinion, there is no role. But we need to check it. I am not 100% sure about this. We need to check out. But I don't think so. There is a role of orthopedic surgery in this case.
But
if someone has confirmed,
there are talks of this neurospine surgery that can help with the kyphoscoliosis.
Maybe I need to check this. Well, I am not sure about this. I will check it out and I will tell you so if there is something like that.
Okay, thank you.
Okay, you did good, mashallah. It was good. So we finished the chest, doctors. Okay, we started from the bronchus, we entered the bronchiole, then we entered the alveoli. After that, we started the interstitium. In interstitium, we started alveolitis. Then we went to the interstitial lung disease. Then we, after the interstitial lung disease, we causes of dyspnea. I don't think so. Because the dyspnea if you have any scenario, send I will see. And in the past,
Dr. Muzammil, your voice interrupted.
Causes by heart. Okay, doctor. Now it's clear, doctor.
Yes.
Yeah, I was telling you that as per my knowledge, we have covered all the cases of dyspnea related to chest and dyspnea related to heart and anemia. But if any one of you have, or any of one of your friend has faced the case that is not covered by these two last sessions, please share with me, because I don't know any case that is not covered by these two sessions of cardiopulmonary that we did the last two sessions. Okay, so inshallah we will find case. The Dr. Sohaib, and I like your approach very much. You ask about orthopnea, PND, cough, occupation, pets. It was a good approach. For every dyspnea, we should ask about all the questions. If we will keep on asking the questions, we will. Yes, one is left. Oh Allah, I forgot. Yeah, very important. We left vasculitis. We forgot. Wegener's. Okay, but we have done vaginous in the last in the previously in the past with Dr. Kamal, so no need to do it again. But very common, very common vaginous. This is coming again in this diet as well. He give you the real scenario that he faced in his Ajman. That patient came with chest infection, not responding to the antibiotics, and inside the patient was giving cough, fever, and the differential diagnosis was for that case is vasculitis, because in vasculitis there is fever. Okay, there is weight loss, there is small vessel vasculitis, there is myoptosis. So the differential for this case was TB. Okay, exposure, if there is exposure to someone, this one atypical pneumonia and vaginous granulomatosis, and you may say also good posture, but vasculitis is the top, vaginous granulomatosis is the top. But if the examiner will say any other DD, you can say I will try to rule out the TB, but in TB there should not be hematuria. Then you can say atypical pneumonia may be one of the diagnoses, but that should respond to the macrolides or antibiotics, and that should not, history should not be too long. So what else left? Any differential, other left differential? Good posture, you can make one differential. Okay, but good posture is not a pure vasculitis. That's why in vasculitis, as you know, TIS, whenever there is at the end synovitis, arthritis, this means inflammation. If there is any ongoing inflammation all over the body in the vessels, patient will have fatigue, patient will have weight loss. I can remember one case, one candidate shared in the group that examiner was telling me why it's not giant cell arteritis, but the patient was having fever, fatigue, weight loss. Why? He was saying it's not due to giant arteritis. He was making infective endocarditis in this case. But doctors, giant cell arteritis can have fever, can have fatigue, can have weight loss, all these features, because that is a vasculitis. So discuss cases more and more with your friends, with your partners, and inshallah in the next session we will start also very common case. We will start diarrhea. If we will do is a PSITT something, you are asking psittacosis like illness.
Chlamydia sitaki, maybe.
Yes, you are very good, doctor, very good. Allah, you raise a very important point. I will check it out. Very good.
Psittacosis.
We need to check it.
Okay,
Very
thank
good,
you.
doctor. Yeah, really very good point. I learned this point from you, and I will read about it, inshallah. That may be psittacosis. Yeah.
And just I want to add, maybe as I remember, in the differential between asthma and COPD, also diffuse lung carbon monoxide diffusion lung carbon monoxide is decreasing in COPD, but maybe normal in asthma, as I remember.
Yes.
But I don't
Yes.
too much trust.
We call it diffusion capacity of the lung, in which we are assessing the diffusion of the carbon monoxide. That definitely that will be low in COPD and will be normal in asthma.
DLCO. Yes, I remember it was DLCO.
Yes, doctor, you are right. But actually, I was asking on the examination. You are right. This we can assess on, because in asthma there is emphysema, and in emphysema the definition of emphysema is that the permanent destruction of the alveoli. Okay,
Alveoli walls,
emphysema,
yes.
alveolar walls. If the, doctor, if I give you a simple example, if there are 200 balls of small size, and if there is a one ball of big size, which one has the more surface area? The small
200 sure
will have more surface area, will get better diffusion of the oxygen, and like this. One big ball, same in emphysema, their interceptor walls are destroyed, and the hundred and thousands of alveoli become few big alveoli. Okay, because their interceptor walls are destroyed, so the diffusion capacity is affected, surface area is reduced. So you are right, but this is a lab result. We were discussing about examination.
Maybe in discussion with examiner. Okay, doctor. Thank you very much.
Yes. Thank you, doctor. About about the next session, inshallah, we will announce in the group, doctor. You are asking. Someone is asking about next session. So, okay, doctors. If no question, I will end the meeting. Okay.
Thank you, sir. Jazakallah.